Assalamu alaikum to all. Today I'm going to discuss about non-invasive ventilation with you all people. The next slide, please. Non-invasive positive pressure ventilation, or NPPV, is usually referred to as to BIPAP, not CPAP. CPAP is continuous positive airway pressure, which is equal to PEEP. The CPAP is usually we use CPAP to improve oxygenation, and BiPAP we use to improve ventilation. In BiPAP, there is a inspiratory positive airway pressure and expiratory positive airway pressure, and the difference between these two is the pressure support, which you usually give to improve the ventilation and the tidal volume and minute ventilation. EPAP in BiPAP mode is equal to CPAP, which is PEEP. Next slide, please. The advantages of non-invasive positive pressure ventilation: it offers benefits of mechanical ventilation without the risk of intubation. It reduces the needs for sedation. Patient retains the ability to communicate, to talk, and it allows intermittent eating and drinking. That's why it's important to put on BiPAP if the patient has the criteria to fulfills the criteria of non-invasive positive airway pressure. Allows it appropriate and concerns for respiration ruled out. Avoids the risk of ventilator-associated pneumonia and other complications of intubation like vocal cord dysfunction and stridor post. Next slide, please. The indications for non-invasive positive airway pressure is respiratory failure. It can be hypoxemic respiratory failure, and it can be hypercapnic respiratory failure. In both these respiratory failures, we can use CPAP or BiPAP depending upon which type of failure patient has. For example, patient has dyspnea, tachypnea, and the patient is using extra respiratory muscles, and there are gas exchange abnormalities. For BiPAP, pH should be less than 7.35, and PaCO2 is, if the PaCO2 pressure is more than 45 and the ratio is less than 200, and the patient is cooperative, we can reduce the risk of intubation, and we can use BiPAP on this type of patients. The next slide, please. The evidence that exists for the use of non-invasive positive airway pressure is, the number one is hypercapnic COPD, the acute and chronic COPD patients. The one thing to remember in COPD patients, if the patient has a normal pH, either the PaCO2 is high or low, in the normal range, it is usually used in acute and chronic COPD, acute exacerbation of COPD, not in stable COPD patients where the pH is normal. The other condition which we commonly use non-invasive positive airway pressure is cardiogenic pulmonary edema, in which to improve oxygenation, we use CPAP to recruit alveoli and to improve ventilation-perfusion mismatch. The third one is acute hypoxemic respiratory failure immunocompromised patients, in which there is a chance of infections. If we intubate them and the patients we put on intubation, there is a maximum chance to get ventilator-associated pneumonia and the complications of the ventilations. To avoid that early, we can use non-invasive positive airway pressure in acute hypoxemic respiratory failure in immunocompromised patients. And we also use facilitation of extubation in the weaning from the ventilator. There is a risk of re-intubation in almost 20%, 15 to 20% of patients. So we can avoid, we can help those kind of patients in facilitation of extubations. The other condition is obstructive sleep apnea or obesity hyperventilation syndrome. The patients who have this condition, they are usually hypoxic, and in obesity hyperventilation syndrome, they also have hypercapnia and low pH. These kind of patients, we recommend CPAP or BiPAP depending upon what kind of hypoxic or hypercapnic respiratory failure they have. The other conditions as neuromuscular diseases, which acts as restrictive lung disease, because in these patients, the lung compliance is reduced because of the restriction of the chest wall, neuromuscular disease. And some other patients in which they are end-stage lung disease like cystic fibrosis or graft rejection, and the other ones are where those have DNI status, like do not intubate, like medical code patients. Next slide, please. Insufficient evidence for the use of non-invasive positive airway pressure is in pneumonia, in asthma, in ARDS, especially if there is a PF ratio is quite much low, if it is around 100 or below 100. So it's there is insufficient evidence. We can use high flow nasal cannula, or we can intubate as soon as possible, and like in COVID patients. Next slide, please. The contraindication, absolute contraindication, is if the patient is comatose, if the patient is unconscious, if the patient is drowsy, and he is not cooperative with the use of BIPAP or CPAP, we should not use among those patients. If the patient is in cardiac or respiratory arrest, if the patient has facial trauma or deformity, or the patient has severe encephalopathy, that encephalopathy can be because of raised CO2. If the CO2 is too much high and the pH is too much low, and the patient is developing CO2 narcosis and he or she has encephalopathy, then don't give BiPAP trial in those kind of patients. Next slide, please. The contraindications which are relative: acute hemodynamic instability, like if the patient is inotropic sport. If the inotropic sport is high, it's better to intubate early rather than to give a trial of NIV. Upper GI bleeding, if the patient is unable to protect his or her airway. Status epilepticus, if the patient has upper airway obstruction like head and neck tumors, extrinsic airway compressions, or angioedema. These are the relative contraindications. Inability to clear secretions, if there are copious amount of secretions and the patient doesn't have the ability to clear his secretions, so it's a relative contraindications too. If there are risk of aspiration, like in vomiting, recent upper way or GI surgery is also in relative contraindications for NIV use. Next slide, please. The continuous positive airway pressure device. It's basically a CPAP is equal to PEEP, which opens the airway, and it continuously delivers a pressure, continuous fixed pressure, which improves oxygenation and improves ventilation perfusion mismatch. And it displaces the pulmonary fluid or edema or anything which the patient is suffering from, decreases the work of breathing and tachypnea, and it also decreases the afterload and helping the cardiac stress. So the main use of CPAP is in those which has the problem with oxygenation, not with ventilation, not with CO2. So these patients will get benefit from CPAP. Most likely we use it in pulmonary edema, either it is cardiogenic or it's non-cardiogenic, and we use CPAP. The next absolutely indication, we use CPAP in obstructive sleep apnea, where there is a closure of upper airway because of the relaxation of tongue and soft tissue muscles. Next slide, please. So these are the different shapes of the mask which we use with NIV. It's a nasal mask. It has advantages and disadvantages. Advantages are it's more comfortable than face mask, and patient can talk, patient can speak. But the main disadvantages is if the patient is a mouth breather, the pressure we want to deliver, it will not be delivered because of the mouth breathing. And the main other disadvantage is the nasal airway passage is narrow as compared to the oral airway. So it needs, it acts as a resistance to apply the pressure. So it's a comfortable one, but it needs full cooperation and more effort, more support from our side, from respiratory therapists and doctors, to assure that, to teach how the patient should visit it. The next is it's a full face mask. It's more comfortable. It's mostly used if the patient is mouth breather. The next one is it's a total face mask. It's the next slide, please. It's a total face mask, and the other one is it's called helmet. Next one, please. In helmet, it's the recent advancement in masks. In it, patient can talk, patient can speak, patient can drink fluids with straw, but the main disadvantage is it's very noisy for the patient. The next one is, please. Now we talk about the bi-level positive air pressure, the BIPAP. It acts like fluctuates airway pressure between inspiration and expiration. We use IPAP and EPAP settings. In inspiration, we set a setting of the airway pressure for inspiration, and we set EPAP for expiration. So it increases the minute ventilation by assuring the adequate tidal volume. And most widely used device allows users to monitor minute ventilation and tidal volumes. The next one, please. Initial IPAP and EPAP setting is 10.10 and EPAP is 5. Subsequent adjustments can be made on the basis of arterial blood gases, which we take after 1 to 2 hours and then 4 to 6 hours, depending upon how the pH and CO2 is improving or not. Increase IPAP by 2 centimeters if there is persistent hypercapnia. The maximum limit nowadays for IPAP is 30, and for EPAP is 20. The maximum EPAP we use is 10 to 15 almost. Always remember I is for ventilation, yani for PCO2, and E is for oxygenation for PO2. Next slide, please. The difference between IPAP and EPAP is a pressure support. The tidal volume correlates with the difference between tidal volume, how much you want to attain a level of volume, a tidal volume of patient's lung is depending upon how much pressure supports you are giving. If you want a tidal volume of 300 and 400 and the patient is not achieving that with the pressure support which you are giving, you can increase that pressure support by increasing the difference between IPAP and EPAP to achieve a acquired wanted tidal volume. And that's the benefit of BiPAP. That's why it improves ventilation and oxygenation too. Next slide, please. Here's a diagram. You can see the pressure against time curve, and the EPAP which usually set in the initial setting is 5, which is almost acts as PEEP, and IPAP is what you set as 10, and the difference between these two is called pressure support, which you usually use to attain a tidal volume, required tidal volume. The next slide, please. Here you can show another diagram, another graph, pressure against time. On the left side, it's the normal breathing curve, and CPAP, it's a continuous positive airway pressure. It's a fixed pressure, which is opening the airway, improving the oxygenation, and it's equal to PEEP. And in bi-level, there is a IPAP and EPAP. EPAP is equal to CPAP is equal to P, and the difference between those two is the pressure support which you are giving. The next, please. EPAP, PEEP, it recruits alveoli. It increases the VQ matching. It improves oxygenation. And IPAP minus EPAP, the pressure support, it increases the tidal volume. It reduces CO2 levels, and improves ventilation and decreases work of breathing. Next slide, please. It's a diagram showing how CPAP and BiPAP works in inhalation. If you can see a 10 centimeter, if you can, in CPAP, a positive pressure is going inside the upper airway and into the alveoli. And in exhalation, when the patient is breathing out, the same pressure is applied by the CPAP. So sometimes it becomes quite difficult for the patient to breathe out against the same pressure which is being given during the inspiratory cycle. In BiPAP, in inhalation mode, it's in inspiratory positive air pressure. For example, you have set it to 20. A 20 cm of water pressure is going inside during inspiration, but during expiration, the EPAP is low, so patient feels comfortable during exhalation. If I and E becomes equal, then it acts as a CPAP. So BiPAP can act as a CPAP. Next slide, please. So the outcomes of non-invasive positive prevention, all the effects which non-invasive positive airway pressure acts on the pulmonary system, the lung airway mechanics is the first of all splinting of the airways to keep the airway open, traction, the positive intrathoracic pressure, positive air, and it decreases the afterload, increases the cardiac output. It increases the lung volume, and it also decreases the venous return. So be careful in the patients who are hemodynamically unstable. They can the positive air, the non-NIV can worsen the hemodynamic instability. And the next slide, please. Let's talk about the different modes of BiPAP. Most commonly used modes we use in BiPAP is ST mode and pressure control volume. And the next one is AVAPS. Mostly in our settings, we use ST mode. In ST modes, there is I and E settings, and there is inspiratory time settings. The major difference between ST mode and PCV mode is inspiratory time. In ST mode, inspiratory time is variable. For example, if the patient triggers his own breath, in ST mode, the inspiratory the time will be reduced according to the patient's comfort. In PCV mode, inspiratory time is fixed. That's the main difference between ST and PCV mode. PCV mode can become quite uncomfortable for some patients, so you have to be careful in which type of patients PCV mode should be used. For example, in which the lung compliance is very low in the patients which have restrictive lung disease, or are the patients which have neuromuscular disease, they have a low lung compliance, and in those patients, the inspiratory time, you have to fix the inspiratory time to achieve a tidal volume to maintain ventilation and oxygenation. In those kind of patients, PCV works better. But other than that, ST mode is perfect because it doesn't fix inspiratory time. That's the major difference between ST mode and PCV mode. Now the advanced mode is average volume assured pressure support. It's a newer mode of non-invasive ventilation. It's auto titration mode. In this mode, it's a difference between ST mode and AVAPS mode. You have in this you set a tidal volume, not the pressure, and you can range the pressure, inspiratory positive pressure from according to the need of the patient. You can set I maximum and I minimum, for example, 20 or 10, 20 or 5, whichever you want, depending upon how much tidal volume or minute ventilation you want to attain that. That's the major difference between ST mode and AVAPS mode. AVAPS usually maintains targeted tidal volume by adopting pressure support to the patient needs. For example, if you have set a tidal volume of 300 in AVAPS mode, and you have given a range of IPAP between 20 and 10, the BiPAP will deliver the desired pressure support to attain that volume, to attain that minute ventilation between those ranges. It has auto backup rate to ensure minute ventilation. AVAPS is also useful in which there is an issue of lung compliance, or it's best used in obesity hyperventilation syndrome, in neuromuscular disorders, and the patient who have restrictive lung diseases. That's the main use of AVAPS, not in hypoxemic respiratory failure. Next slide, please. These are the variables, nasal or oronasal or face mask advantages, disadvantages. You can see from the slide, the most comfortable one is the nasal one, and it permits expectoration. It allows the speech. But the main disadvantages, the other benefits like rebreathing or lower CO2, nasal has less advantages other than oronasal. Next slide, please. It's a normal anatomy and function. You can see tongue and the soft tissue around the tongue and the epiglottis Airways open when you are sleeping. There's no problem. Next slide, please. In this obstructive sleep apnea, during sleep, you can see tongue and soft tissue has fallen back because of the muscle relaxation and the upper airway is blocked. Now, it's quite difficult for the patient to breathe in during sleep. That's why we use a CPAP therapy to open the airway continuous positive. Next slide, please. You can see we can use CPAP, which allows a continuous positive airway pressure to keep the airway open and the epiglottis open to move the air inside the lungs. Next slide, please. What are the predictors of failure or successful of non-invasive positive air? Definitely it's CO2 and pH. If the CO2 has improved more than 8 in first hour and the pH has improved 0.06, then you can say the NIV is being successful. And the predictors of failure are definitely, again, the PCO2 and pH. If the pH is still falling and PaCO2 is still rising and the patient is going into narcosis and encephalopathy, these are the predictors and the failures of NIV, and you need to intubate that patient. Next slide, please. NIV in COPD with the different conditions. Let's discuss the different condition in which we use NIV. The first condition we use NIV is COPD. Patients with exacerbation of COPD are the most benefited from NIV. NIV is important to adjunct to other conventional therapy like the medications and all the bronchodilator therapies. It reduces the risk of intubation and thereby preventing its complications like ventilator-associated pneumonia and others. The best responders are those who have the pH of 7.2 or more than 7.2. Also effective in patients of pH of 7.35 and 7.30. But if the patient has a pH of less than 7.20, then you have to be very keen because NIV may fail and you need to intubate that patient. Mostly the patients who have a pH of 7.20 or more than 7.20 will get the most benefit from NIV in COPD exacerbations. Next slide, please. In pulmonary edema and congestive heart failure, cardiogenic, either it's cardiogenic or non-cardiogenic, we effectively treated with CPAP. There is no difference in mortality noted between CPAP and BIPAP. BIPAP can be used as a CPAP if I and E becomes equal. Benefit is seen after 2 hours of therapy. And you should give a trial of if the patient is hypoxemic and patient is in acute pulmonary edema and the patient is conscious, not too much inotropic sport, then in those patients, you can try a CPAP to avoid intubation in those patients. Next slide, please. The mostly we use NIV is after extubation. Post-extubation respiratory insufficiency can occur in 20% of the patients. For weaning from the ventilation, invasive ventilation, and to prevent the post-extubation respiratory insufficiency, we use BiPAP. We commonly use in our settings, in ICU settings, and especially with the patients who were intubated because of COPD exacerbations. Next slide, please. Now let's talk about the troubleshooting. What problems we can face during NIV use. The most important is mask intolerance. Most commonly encountered problem with our patients, mask fit is optimal and minimal strap tension is used to control the air leak. Patient should not be forced to use mask for more time that they can tolerate. So it depends upon the patient's cooperation and the patient ability to tolerate this NIV and the mask. Next slide, please. The next complication we commonly encountered in our setting is nasal congestion. Both nasal congestion and dryness can occur during NIV. We can overcome that by using inhaled heated humidification, now which has become standard, and it comes with all the BiPAP devices. Dryness may also respond to nasal saline, norsaline drops, and water-based nasal gels. We can overcome that dryness, but nasal congestion, they usually respond to inhaled steroids and antihistamines. Next slide, please. By nasal bridge redness or ulceration, because of the mask use, we can minimize that by strap tension, and we can apply Duoderm on the nasal bridge, switching to alternative masks such as the bubble mask or nasal pillow or full face mask or even the helmet. We can overcome that complications by NIV use. Next slide, please. The ATS guidelines, which the recommendation by European Respiratory Society and American Thoracic Society by NIV, and the recommendations are the strong recommendations. I'm gonna tell you in the next slide, please. NIV should not be used in patients with hypercapnia who are not acidotic in the setting of COPD patients, the chronic COPD patients who have a normal pH with high CO2. It should not be used. It should only be used if the patient has low pH, acute on chronic settings, not in chronic and stable COPD patients. Bilevel NIV for the patients with acute respiratory failure leading to acute on chronic respiratory acidosis, if the pH is 11.735 due to COPD exacerbations. CPAP for the patients who have cardiogenic pulmonary edema. CPAP or BIPAP should be used in the patients with acute respiratory failure due to pulmonary edema in pre-hospital settings. No recommendation on the use of NIV for acute respiratory failure due to asthma or pneumonia even. Early NIV for immunocompromised patients with acute respiratory failure. Conditional recommendation, moderate certainty of evidence is there to prevent the risk of intubation and post-intubation complication, which usually these patients, immunocompromised patients, have more other. Next slide, please. Next slide, please. Non-invasive ventilation for the patients who have post-operative acute respiratory failure, upper abdominal surgery patients. We can use NIV in those patients because of the diaphragmatic distress. NIV for palliation in terminal conditions, the medical code patients. NIV for chest trauma patients. In flail chest, we can use NIV. No NIV in acute respiratory failure due to viral illness. Most likely, we have to intubate them if there is a need of hypoxic respiratory failure. NIV should be used post-extubation in high-risk patient who may require re-intubation. NIV should not be used in post-extubation respiratory failure. If there is a failure, post-extubation respiratory failure, then it's better to intubate early. Not if it can be used for the weaning purposes, but if there is a respiratory failure, try to intubate as soon as possible. NIV to facilitate weaning in hypercapnic respiratory failure. These are the guidelines which ATS and ERS have established in 2017 for NIV use. Thank you.